Hello everyone, welcome to my video channel. Today I am going to talk about DCO, Damage Control Orthopedic, Part 3. In this video, I will cover regarding definition of shock, based on the case scenario, how will you manage this patient, what is a borderline patient definition, what is the timing of surgery for the case scenario, and the window of opportunity, and another additional notes regarding ETC, Early Total Care. Before we start, there is a disclaimer, and the disclaimer is the same in all my videos. Thank you. Now let's begin. So define shock. Shock is a state of generalized cellular hypoperfusion leading to inadequate cellular oxygenation to meet metabolic demands or needs. Organ tolerance to ischemia for the heart, brain and lungs. The warm ischemia time is around 4 to 6 minutes. For the kidneys, liver and GIT, gastrointestinal tract, the warm ischemia time is 45 to 90 minutes. For the muscle, bone and skin, the warm ischemia time is around 4 to 6 hours. In the state of hypoperfusion, the patient is losing blood, hypovolemic shock. There is loss of circulating volume, that means fewer RBC, red blood cells, circulating through the capillary beds to deliver oxygen to the cells. Lack of oxygen will impair metabolism of the cell. So you must remember, every RBC is important. Classification of shock in trauma setting. It can be divided into 1. Hypovolemic shock due to blood loss. Number 2. Distributive shock. Example, in patient who has a cervical fracture that develop neurogenic shock due to decrease in the systemic vascular resistance. Number 3. In cardiogenic shock, in trauma patient, the shock can be either due to A. Intrinsic causes or B. Extrinsic causes. In intrinsic cause, the causative factor can be due to blunt cardiac trauma leading to muscle damage and or dysrhythmia, or it can be due to valvular disruption. For extrinsic causes, it can be due to either pericardial tamponade or tension pneumothorax. Based on the last clinical scenario, 20-year-old male post-motor vehicle accident noted in emergency department with BP of 100/60 mm mercury, pulse rate of 120 beats per minute. There is bruises in the abdomen with a seat belt mark. So how would you approach this patient? After I have done ATLS, acute trauma life support with adequate resuscitation, I've noticed that this patient is a transient responder. The pathology is due to 1. Posterior wall of less acetabular fracture is undisplaced in nature. Number 2. Patient also has a chance fracture of lumbar 1 L1 with no neurological deficit. Number 3. Intra-abdominal injury is treated conservatively by the surgical team. Number 4. There is an open fracture grade 2 mid-shaft of left femur. The question is, how do you manage the orthopedic fracture based on DCO protocol? You must remember, the purpose of DCO, Damage Control Orthopedic, is to minimize the time of surgical intervention and bleeding, thus reduce to a minimum the second wave of a post-operative complication. Based on the scenario, this patient is a borderline patient. The patient fits into borderline patient category if he or she has 1. Polytrauma, where the ISS injury severity score is more than 20 and additional thoracic trauma AIS thorax is more than 2. Polytrauma with abdominal or pelvic trauma, more 3, and hemodynamically in shock, whereby the initial blood pressure is around 90 mm mercury. ISS 40 or above in the absence of additional thoracic injury. Radiographic findings of bilateral lung contusion, bilateral femoral fracture, severe head injury, initial mean of arterial pressure 24 mm mercury, with pulmonary artery pressure increased during intramanually nailing 6 mm mercury. The borderline patient represents the most controversial category in which the choice between ETC, early total care, and DCO, damage control orthopedic, remains uncertain. Pape et al. Coined the term borderline to describe a patient who is apparently in stable condition before surgery, but who deteriorates unexpectedly and develops organ dysfunction post-operatively. Factors with poor outcome in a borderline patient include patient presented with hemodynamically instability, coagulopathy present, hypothermia with the temperature is less than 35 degrees Celsius, patient in acidosis where the pH is less than 7.24, presence of massive blood transfusion, more than 10 units of blood and blood product transfusion, where the expected operative time is more than 6 hours, and the presence of raised inflammatory markers. DCO, damage control orthopedic, is all about minimizing the second hit that usually occurs in the 2nd to 5th day post-injury. In this time period, the initial severe trauma can result in a life-threatening inflammatory response SIRS. Based on the graph or illustration on the left side, when the first hit occurs due to trauma itself, there is already a raised inflammatory response that occurs. After the inflammatory response becomes less throughout the time, then the second hit will occur during the surgical intervention. In some patients, the lengthy surgical time involved in ETC, early trauma care, exacerbates the SIRS, resulting in multi-organ failure and death. Usually, the timing of surgery depends on in day 1, it usually advocated in the early trauma care ETC or in a stable patient. In day 2 to day 5, we should avoid doing any surgery unless it's a life-threatening or a limb-threatening condition. At this time, sustained immunologic changes are still ongoing and there is a fluid shift. There is an increase in generalized tissue edema that are not yet normalized. SIRS is rampant in this period of time and second hit is common. In day 5 to day 10, this is the period defined as a window of opportunity. However, the waiting period should be shorter than 15 days since it has been shown that contamination rates in external fixator pin sites rose substantially after 2 weeks. Based on the earlier scenario, the question is the patient has one posterior wall of less acetabular wall fracture, undisplaced in nature. Number 2, chance fracture of lumbar L1. Number 3, open fracture grade 2 mid-shaft of left femur. The question is, how do you manage the orthopedic fracture based on DCO protocol. Again, in conclusion, DCO seeks to avoid provoking a severe inflammatory response and confine itself to the more modest goal as sufficient stabilization of fracture to prevent further tissue damage and potential compartment syndrome and potential fat embolism syndrome, especially in a long bone fracture patient, to permit better positioning for the patient care and improve pulmonary care, again, without the potential adverse effect of early definitive fixation. Based on the earlier clinical scenario, we need to address the number 3 first, the open fracture grade 2 midshaft of left femur. How? This is by doing a wound debridement and tibial pin insertion with traction of the left femur is considered faster. Or we can do a wound debridement at external fixator of the left femur. The problem with wound debridement and external fixator of the femur is we need to close the open wound within the 14 days and change the external fixator to internal fixation to prevent pin tract infection. The management may vary, depends on the surgeon and practice in different centers. Window of opportunity is within day 5 to day 10 post-trauma. Again, in this period of time, once the patient is more stable, address the internal fixation of the femur by doing an intramural nailing. The acetabular wall fracture is treated conservatively due to undisplaced in nature. For the bony chance of L1, we can address it by doing an MIS, minimally invasive surgery with shock segment fixation. This procedure can be discussed more in the spine topic video. I just want to add an additional notes regarding early total care, ETC. It is usually a definitive fracture treatment that is done within 24 hours. It is done in a stable patient with lactate level is less than 2.5. Please avoid in patient who has thoracic injuries, hemorrhagic shock, and patient who has head injury. The advantage of ETC, early total care, is it provides pain relief due to fracture immobilization with fixation, less infection because already we reduce the soft tissue trauma damage due to mobility of the fracture itself. It allows for early mobilization and prevention of thromboembolism due to early mobilization. Finally, that's all for today. I hope you have learned something from this video. Till we meet again, see you and bye.